and at the bottom end of the femur with a lot of very interesting detail. And my remit is just to cover the gap in between the two, the interprosthetic fracture. And this is often one when it goes up in the trauma meeting in the morning where you get a sort of sinking heart and a sense of doom as you look at the patient and at the technical challenge of the fracture. I can only repeat what the previous speakers have said. This is an epidemic of gradually increasing proportions, indeed exponentially increasing proportions, with these awful risk factors of increasing age. And not only increasing age, but the patients are surviving longer with increasing numbers of comorbidities because of improving medical care in conditions like rheumatoid arthritis, with inflammatory disease, osteopenia, and often 1 or 2 previous arthroplasty attempts. This paper by Clive Duncan and Faraz Haddad has been mentioned a couple of times already this morning. Clive Duncan was the chairman at the University of British Columbia in Vancouver and originally produced the Vancouver classification of ABC. And Faraz Haddad, who is the editor of the Bone and Joint Journal, and he then collaborated to expand that classification to add D, E, and F. And quickly, just to go through what those are, you're familiar with the A. And certainly in English, they've attempted to add a key word with that letter to aid memory retention of what this classification is. So A is an apophyseal fracture and greater or lesser trochanter at the top of the femur. B is a fracture of the bed, and we're aware of the type 1, type 2, and type 3 fractures here. I guess one of the important differences between my practice and the practice that they have in Vancouver is that almost all proximal femoral prostheses are uncemented, leaving that very small gap of cortical bone around the prosthesis to grip with screws. Whereas in my practice, and I think probably in yours as well, we have the advantage of a history of having cemented prostheses with narrow metal stems, which provides you with a nice big bed of cement into which screws can get a decent grip. And so the difference between B1 and B2 in a cemented, narrow, taper, polished implant is maybe not as important as we think. So in an uncemented implant, if it's loose, and it's gone. In a cemented implant, if it's loose, but it's a tapered stem, and the cement around that stem has fractured with the bone, our usual practice is to repair the cement fracture along with a bone fracture, recreating the cone into which the tapered stem fits. And that works very nicely in a way that just wouldn't work with an uncemented stem. So an important difference depending on whether you're working with cement or not. C fractures, as you know, are those that are clear of the implant bed, and then the additional fractures described by Duncan and Haddad are the D, the interprosthetic fracture dividing 2 implants, the E, which is each of 2 bones supporting 1 arthroplasty. So here we have a total hip replacement with both the femur and the acetabulum fractured on each side of that total hip replacement, each of those 2 bones. And then F is the bone facing an implant. So a hemiarthroplasty here. The femur around the hemiarthroplasty has survived, but the facing bone, the native acetabulum, has fractured. We've talked a little bit about how to treat these fractures and how to avoid them. Quickly to run through these. It's important, if you can, not to get into this situation in the first place. We've already seen one slide earlier in the morning talking about this concept of kissing implants and 2 implants approaching each other with a narrow elastic segment in between is clearly a risk. The second is the presence of drill holes. This is a case very much like Sven's one that he showed earlier with an open fracture that was initially bridged with an external fixator to allow treatment of the soft tissues. And you can see the X-fix has left some holes just in between the zone of the 2 implants, and you can imagine what happened next. And then finally, during the course of arthroplasty, it's important to avoid perforation of the cortex with cement extravasation, again, clearly leaving a point of weakness for future fracture. So how not to get into that situation in the first place. So what options do we have when we have an interprosthetic type D fracture? Very few. We can't come from the top. It's difficult to come from the bottom. We know the hazards of coming from the side and disrupting the extra osseous circulation. And really, we're very constrained in our list of options. So what are they? Well, first of all, non-operative treatment is always an option. In the upper limb, at least, where we have a fracture separating a shoulder and an elbow, and the use of a Sarmiento-type brace over the course of a prolonged period of 4 to 6 months is often successful in getting these to heal, but obviously not applicable to the lower limb. In the lower limb, options are fixation, and we've heard some lovely talks about the fixation options both at the proximal end and at the distal end. And you can see here a description of how it is very useful at the top end to have a cemented implant with the ability to place screws back and front of that. The same is true in the upper limb, where plating either with bone or with metal is possible, and the use of strut allografts adds an extra dimension in those situations where there is a poor bone stock, as we've heard already this morning. I have a pointer failure just for a moment. One option that's used largely experimentally or on the hoof is a linking device. We don't use these routinely, and I don't believe there are many that are commercially available, but certainly on an individual basis, a linking device that feeds into the tip of the stem, both proximally and distally, and allows screw fixation of those two is very helpful. There is some experience in doing that with sawn-off nails intraoperatively, just bashing the two ends of the prosthesis in. But really what we come down to often is the concept of massive replacement. And the massive endoprosthesis, going from the hip to the knee, is often where we end up in these fractures when bone stock is poor and the patient is sick, both in the upper and in the lower limb. The one thing that's helped us recently to increase the number of patients that we can plate rather than move to endoprosthesis is new plating systems. And we've already heard a little bit earlier on today about the use of plating systems that allow a much broader plate with smaller holes for smaller screws that allow you not only to pass a bicortical screw directly through the bone, but also to come around the prosthesis and attack it from the sides. And several of the companies are producing ones like this NCB plate, where these small screws in a sort of approaching orientation allows us to attack these stemmed implants rather more easily. So the femoral endoprosthesis. Here's a typical situation. We've got an elderly patient, a type D fracture. You can almost see through the bone there. It's clearly very osteopenic. An initial attempt was made to plate it, just as you've seen earlier on today. They've had a prolonged, rather uncomfortable period of 6 months of non-weight-bearing, waiting for the fracture to heal, and the patient has become rather fed up and bored with their treatment, and then becomes increasingly fed up when the prosthesis, when the plate fails. And this is one that is typically salvaged by a massive endoprosthesis of the distal femur. Note that right at the top of the X-ray there, we've now got kissing implants between the end of the total hip replacement and the top of the total knee replacement. And to avoid the future fracture, a plate has been added to this construct on the outside just to bridge across this area of kissing implants and to try and reduce the chances of the next inevitable fracture. So what are our results for this distal femoral replacement? In Edinburgh, we've had we've looked at the last 25 patients that we've treated over the last few years. The median stay is just 19 days. They do mobilize rapidly and get out, but they're a sick population, and inevitably, like the total hip replacement population, there's a relatively high rate of early morbidity and mortality. Their functional outcomes are not great. The SF-12 physical score out of 100 is just 52, and the extremity salvage score at 69 also represents poor levels of general mobility after, although it is better than having an above-knee amputation. The prosthesis tends to work fairly well. We've got a 5-year implant survival of 90%, but bear in mind that it's reflected by the sickness and frailty of the population that the actual patient survival is considerably less than the implant survival. Proximal femoral replacement, very similarly. The crucial thing is to avoid complications. Once a complication has occurred in either a fixation or an arthroplasty patient, the final outcome is far, far worse. And complications are common in this group of patients with previous multiple surgeries, with persistent infection and refracture. So it's major surgery with a high morbidity and mortality. Complications when they occur are devastating. And salvage options once you've had a total femoral replacement are limited really to amputation. But the advantages are early mobilization, the ability to allow the patient to be fully weight-bearing straight away, and a relatively quick and technically easier procedure. Thank you very much.